How you doing? Thanks for joining us on this beautiful Wednesday evening. I'm here with a great doctor who's local, right in Culver City, David Schechter. Thank you for joining us tonight. I really appreciate it.
Good to see you.
And David's a specialist in family medicine, sports medicine, and pain management and mind-body connection, you know, which is a fascinating part of our business. As I always say, energy equals mass. Einstein proved that. You know, he's a smart guy. I trust him. And this distinction between when does the mind end and the body start, especially when you're treating pain, is something we don't know the answer to, you know, fundamentally. But as a spine surgeon, I'm dealing with pain all the time. Sometimes I can see things I can operate on. Other times we can't necessarily. We got to work that out, try and quantify how much is the mind versus the body, or a bit of both. And so it's something we struggle with all day long. Patients I have in neck pain, back pain struggle with it too. And so I feel really blessed to have you, and to have you as a resource right down the road, so close to us, because this is a difficult part of medicine, how to work this out. And so I'm really happy that you joined us. Thank you for being here. As our intro, you know, John Sarno was the godfather of mind, body, pain. He's from New York. He passed away just a couple years ago. In fact, who's the guy who always talks about him on the radio?
Howard Stern.
Howard Stern loves John Sarno. I've heard from 10 patients that. Yeah, and I had a patient, a friend of mine, who had pain and read John Sarno's book and got miraculously better. So I looked into it, and he was the godfather of the mind-body connection, and you trained with him and picked that up, and I was so excited when I found out that you're actually here in LA and it's such a great resource. So you want to tell us a little about your introduction and where you're from and everything?
Sure. I'm originally from New York, and after going to college at Princeton, I ended up at NYU Medical School, which was fortuitous because having knee pain that wouldn't go away, I tried the usual conventional approaches. I saw a top orthopedist who was the Yankees team physician at the time, and they couldn't figure out exactly why my knees kept hurting. The testing wasn't that revealing of anything structural. So I walked into John Sarno's office expecting to get some type of high-tech rehabilitation, physical therapy, something that was different, that would help me, because I was very frustrated as a first-year medical student not to be able to get the physical releases from running and basketball that I enjoyed. And he looks at me and he goes, "Tell me a little bit about your story." I told him my story briefly. He said, "You know, 95% of this pain that persists, this chronic pain, is psychosomatic.
Yeah.
What do you think of that?" And I go, "Whoa." And it was like getting hit with a blast of cold air in my face, because it was not what I was expecting to hear. He said, I see you're a little bit tentative about that, but come to my seminar that I do for my patients next week, and if it interests you, I'll examine you gratis as a medical student and tell you if, you know, I think this diagnosis applies. So the next week I go to a lecture that he offered regularly to his patients, and there were a bunch of well-dressed Upper East Side, Upper West Side, Manhattan folk in their 30s, 40s, 50s, and I was a 21-year-old, 22-year-old medical student with my probably corduroy pants and whatever shirt I could put on that day.
Right.
And he laid out this schema that just made a ton of sense to me, which is I was just doing a little bit too much worrying. I was stressed out by medical school. I wasn't enjoying the transition between what I had studied in college, which was a little bit more thought-provoking. Now you're taking multiple choice tests your first year in medical school. It's not really what you signed up for when you're a doctor, but you got to get through that to get onto the clinical rotations that, of course, most people enjoy a lot more. And so he lays out this whole schema, explains how one's personality, one's background, stress, emotions, all figure into pain, explains how it works. And I leave the lecture that evening, go back to my apartment, my little tiny room that I had rented from someone, and I felt like a weight was lifting off of me.
Mm-hmm.
And I had that experience of, that's it. I've just been wound up in this thing. And so I started to get better very quickly. I went to a couple other seminars. I was examined by him. He confirmed that I had the diagnosis that he calls TMS.
Yeah.
Originally it was tension myositis syndrome, tension myoneural syndrome. Doesn't really matter what you call it. None of these names are great.
Yeah.
But this is what it is. It's physical pain, but its ultimate trigger is stress and tension in the mind and brain. And before you know it, I started jogging. I started playing basketball again. I felt like I was back to myself. I thought, this is amazing. When I discussed it with other medical students and physicians at NYU, I got a lot of, you know, kind of.
So are you saying you're crazy? Like,
yeah,
right.
It's all in your mind. I mean, what does that mean?
Right.
And so of course, I learned to be a little more cautious with that. But the following summer, I got a little research grant. I was able to spend the summer with Dr. Sarno in his office, calling up 177 of his former patients, doing a follow-up study, and kept hearing the same types of stories over and over again that you alluded to in your friend who read a book, and that I personally had. I kept hearing these amazing stories of people who had been through the physical therapy and other approaches that hadn't helped them. So that solidified my interest in the field, and also I got to see a lot of patients with him, so I learned a lot more about how he approached the problem, and that was my introduction to it.
Yeah, that's awesome. And it's so powerful. And I've had a similar experience where I was having neck pain and back pain when I turned 40. I'm 47 now. And I read Sarno's book, and I did some processing and really breaking down, quantifying. One thing I liked about Sarno's diagnosis, he says this happens to type A personalities. To some degree, you kind of think you're weak. If somebody tells you have a psychosomatic disorder and it's all in your brain, you kind of think it makes you weak. That they're calling you weak, that your brain is taking control and you can't control it and you're out of control. And in fact, it's really the intense people, type A's, who want to control everything, this kind of stuff, are most prone to get this. I mean, it can kind of happen to anybody, but that's the typical personality, isn't it?
Right. We talk about, I modified a little bit to call it type T for tension.
You're right.
And instead of, it's focused a lot on people who are hard on themselves, perfectionists. If you're going to be a surgeon like you are, you have to do a pretty perfect job there most of the time.
Right.
And so perfectionism, people-pleasing can also be a factor, how we are sensitive to others' critiques of us. And, there's a number of these personality factors that go into this type T personality, I call it.
How much did John Sarno spend on the diagnosis of spending time with people to really understand their psychological background? How much of a therapist was he when he was diagnosing people?
It's a good question. He was not a therapist, but he was a very forceful person. And so he would review the history with the patient. He would do a brief exam, all the neurological stuff we traditionally do when someone has, let's say, back pain, reflexes, sensation, all of that stuff. And if he concluded that you had this TMS condition, he was just real forceful with it. So people would say, well, should I keep going to PT? Should I see a chiropractor? Should I take these medications? He'd go, that's nonsense. Stop doing that. You just need to think differently. You need to start. And this was before he had written his book, because his first book, I helped him with the editing.
No, did you? Cool.
Yeah. And he had not written any books yet, so it was really about his visit, his personality, his lectures. But he wasn't a psychologist. He just was very attuned to the fact that psychology was important.
Right, and that's interesting about being forceful, because sometimes that's what people need to hear. Is this is what you have, this is what to do, stop worrying about it, do this. And sometimes that relieves the burden of people, of all the too many options and choices.
Well, he told me that the two keys to getting better from this condition that we'll go on a little more later and talk about is accepting the diagnosis and then shifting your thought from the structural to more of the psychological and stress and that type of thing. So accepting the diagnosis is where people often have resistance. And that's why when they do come to me, and I have people seeing me not only in the local area, but I have people traveling to see me from quite far away, in Northern California and Arizona and other places. And they really need to hear from a physician who's treated thousands of people with this method that you have this condition. So that clear diagnosis, when I can make it, I can't always make it. There are people who have a mixed picture. Maybe we'll talk about that. There's people who have a structural problem, and then I pass them on to you to deal with. But for people who have this amplified stress-related pain that's really not coming from a purely structural problem, it's not really coming from a structural issue at all, at this point in time and at the chronic level, it's coming from the brain, the nervous system, and the emotions. If they can accept that that's what it is, they make great progress. If they don't accept it, that's the challenge.
Yeah. So how do you make the diagnosis?
Well, I mean, a lot of it is the due diligence. So I start off, and obviously I take a careful history, as any physician would. Now, many of my patients have seen 10 to 20 physicians or more before they've seen me. And that's one of the ways that actually makes it easier for me to diagnose them, is that they've seen plenty of good people.
And so they've ruled out any real functional thing that could potentially be operated on. Generally.
Structural problems, typically.
Right.
But then I'm broadening the question. So I'm not just asking about, does the pain shoot down your leg, or does the pain worse when you cough? But I'm also asking some important questions that don't typically get asked in the doctor's office. I'm asking them, what's going on in your life? I'm asking them, what was your childhood like? I'm asking them, are you that type T personality who's hard on themselves, a people pleaser, a perfectionist, a worrier? I'm asking them if they've ever had other stress-related conditions in the past, like tension headaches, irritable bowel syndrome, and migraines and things that might have a stress-related component. So I'm asking these other questions. I'm broadening the scope of the interview from simply the musculoskeletal or the pain area to the broader psychosocial area, and that seems to make a big difference. And then I'm examining them. In the course of the exam, I do look for these 6 tender points that Sarno frequently identified were associated with TMS, which are myofascial tender spots in the trapezius, and for those of you who are medically inclined, otherwise you'll have to look at the diagrams I have in my book and things, but side of the quadratus and the upper gluteal.
Yeah.
Typically people have these spots, and these are different spots than the fibromyalgia points that some of you may have heard of which there are 19 and you're supposed to have 12 and all this sort of thing. But there's an overlap, but they're different spots. So if they have that as well, that helps to confirm it. And I look at their MRIs very carefully. I fortunately have had a lot of experience in reading MRIs and spent some time many years ago working with a spine group earlier in my career, so I got pretty good at reading MRIs. And I really want to give them an objective review. I don't want to say to them they have this condition just because they walked in the door wanting that diagnosis or just because I suspect they might have it. I want to make sure there's nothing structural that's contributing. And sometimes there might be a debate. So one person said, you know, hey, that foraminal narrowing is important. And another physician said, no, I would never operate on that. It's not a surgical case. So I try to give them that additional opinion. And then we're at the point where I'll either say to them, you have TMS, or I might say to them, you have TMS, but it's a mixed picture. There is some structural element, but I think the amplification by the emotions is crucial, and we can work with you on that. Or I might say to them, you know, in this particular case, it's spinal stenosis, and unfortunately, I can't fix that with this problem, with this approach. I'm sorry. And although occasionally I've had some interesting responses to even spinal stenosis, but you know, sometimes it is structural.
Yeah, and the mixed picture is an interesting one because what I do with patients if I'm talking to somebody and I really sense the tension in them and you get a feel for that. A lot of times what I'll say is, look, here's what I see on your MRI, here's what you got physically, here's what your exam shows, here's a potential surgery. But I think you have a decent amount of this stress and tension being held in your body that is manifesting as pain. And I might just say the mechanics that I love are chronic muscle firing causes anaerobic metabolism, a lack of oxygenation. The Krebs cycle, to make ATP, your body does the Krebs cycle. Lactic acid is a byproduct of the Krebs cycle. Lactic acid is a pain mediator that builds up in the muscles. There's a physiologic basis, which actually, you know, as a surgeon, I'm like, okay, I got that. There's some physical deposits of pain mediators there. And I love Sarno's saying about you got to do cardiovascular exercise to wash out the lactic acid, release endorphins, feel better. But my point about what I tell patients is I try and make it so they understand there's a physical component here that is real that you feel, so they don't feel like you're just blowing them off or telling them it's all mental. This is a real connection. But the other part about what I was going to say about that is that what I need patients to do is to help me quantitate. I need them to read your book, and I'm going to put a link to your book on the bottom of this. It's a great book, and it's got, you took Sarno saying you took it a step further. We'll get to that. But I need you to read this and read Sarno's book and get an understanding as to how much of this applies to you and try and quantitate for me how much of your pain is related to stress and emotional anger and tension you're holding in your body. Because if it's 80%, we don't want to operate on you. If it's 20%, well, then maybe we'll do the surgery to fix the other stuff, but we got to try and quantitate this in the mixed bag.
Well, there's 2 or 3 very important points you brought up. I feel like I could speak for the rest of the hour about just those 2 or 3 points. But one of them is that TMS, this condition that I'm discussing, is real physical pain. It's not imaginary. It's not made up. It's not malingering. It's real physical pain. And the mechanism that you described of muscle tension, tightness, you know, you could think of if you just contract your biceps muscle, but just hold it, not for 5 seconds, but for 5 minutes, it will start hurting. There's a buildup of lactic acid, a decreased oxygen in the area, and it will hurt. And so if you're doing that at a lower level in your back for hours or days or weeks, clearly that will hurt as well. So that's one way to think about this that's valuable. Another thing, as a surgeon, and there's a surgeon up in Seattle that came to this approach, is that if you have this sense, and you're unusual in that you have these instincts about people's personalities, not just their spine, but if you have this sense that emotions are playing a role, even though there is a structural thing that you might eventually want to deal with surgically, you might want to put them through, as this doc up in Seattle, who's written some books, and I can talk to you about him later, put them through a 4 or 6 week program where they're doing some things that lower their tension and stress. It might be a couple of the apps that are available now online, you know, the Headspace and the meditation, the Calm, these sorts of things. It might be journaling. I use a lot of journaling as a technique to release stress and tension, where people will sit down with a notebook or with a book I've written called the Mind Body Workbook, and they'll write about their feelings every night for 10 or 15 minutes.
Yeah.
It might be increasing their aerobic activity. It might be really trying to think about the things in their life that are putting pressure on them, that they're putting pressure on themselves about. So that could be a preamble, so to speak, and if you see them at that 6-week follow-up and the pain is mostly gone, well, you don't operate on them. If you see them at the 6-week follow-up and they seem calmer and they seem less worried and they've been doing the thing, but they still have the same pain, obviously it's going to be a better surgical candidate for you. So that was another thought that came to mind in that regard.
Yeah, that's great. And keeping a journal is amazing, isn't it? We all should be mandatory keep a journal for 5 minutes every day as a human being, so you get some of these thoughts out. And once you start to write, more comes out, and then you start to really realize how you feel about something. It's an amazing process. And I love that you have that in your technique and in your book of how to a structured journal for what questions should you be going over and to stimulate, and how should you answer it. I think that's a great technique that you offer.
Yeah, it's been very effective with patients. Sometimes people initially have a little resistance, but what we've learned is actually handwriting it out in a notebook, which you can get at any retail store or online, or the workbook that I have that has structured questions to ask. Actually writing out is the most effective. And this research has been done on this. The second most effective is typing it out, like on the computer. The third most effective is recording it, like recording it into your iPhone or your recording device. The least effective is just reading the questions and thinking the answers. So there's something about tangibly doing it, and the handwriting seems to connect to the neural pathways in the brain a little more effectively.
Well, that's awesome. I didn't think about that, how, a lot of this is the thoughts in your head and how they manifest physically. Well, in some ways, you need the therapy is to physically write these things out, to physically do the process to reestablish the connections and to change the connections. That's awesome. And anybody who's ever kept a journal knows that. You broke up with somebody, you're feeling depressed, you start to write, you start to feel better because you're getting out these mental and physical connections and reestablishing them. That's awesome.
Typically, you'll feel better, and there's a smaller percentage of people who start writing and realize, you know what, I've got a lot of stuff in here I need to deal with, in which case I can refer them, or you could refer them, or they can be self-referred to a good psychotherapist who does work in that area.
Absolutely.
And I work with a network of people who work specifically in the pain TMS psychotherapy area, but any therapist can at least help you if issues come up in the journaling that suggest that they're more than you can handle yourself.
Yeah, cool. What other techniques do you typically do for people who you've made the diagnosis in?
Well, Sarno used to say that education is the penicillin for this condition. So as you alluded to, getting people to read things, getting people to listen to podcasts, getting people to review YouTube videos. I have kind of a curated list that I give to patients in my office. I have a number of things on my website as well that you can link to, that you can listen to. But education's the penicillin in that you've probably had a lot of messages from other physicians or physical therapists or chiropractors that now will turn out to be counterproductive to your getting better, because those messages focused purely on the idea that there was something structurally wrong. And if you have TMS, you need to be thinking about it in the way of, I can get better, I just need to work out the emotions and the stress and that sort of thing. So education's very important. I really empower the patient to study these materials a little bit at a time. They don't have to do a 48-hour weekend on it, but just a little bit every day. Combine that with the journaling, follow-up visits with me maybe 3 or 4 weeks after the initial visit if they're patient, and where appropriate, the psychotherapy. And who gets that referral just depends on what's going on in their life. If they had a very complicated childhood, they might be more likely to get a referral to a therapist that can work with them on those more complex issues, or if they're not responding relatively quickly to the program.
One of the things I also took away is from what I remember Sarno saying, basically, is just get on with your life. Stop going to physical therapy, get on with your life, and just live your life, which is kind of that balance between, what I basically tell patients is you got to do cardiovascular exercise, get your heart rate up, break a sweat, move your body. And you got to be resourceful and persistent and flexible, where if that means get in the pool with old people and do water aerobics, do it. Do whatever it takes to move. Do Tai Chi, do yoga, run, bike, swim with a mask and a snorkel, whatever it takes. Do you kind of think that too? Any cardio you can do will help you overall?
Moving is very important, absolutely. I mean, it first of all reinforces the idea that your body is okay rather than that it's sick.
Yeah.
Secondly, it demedicalizes you. So you're going to appointments, like going to regular therapy appointments, physical therapists, that sort of thing. And by the way, I'm not in any way against physical therapy. I refer to them a tremendous amount for acute pain, acute injuries, sports injuries, all of that.
Yeah.
When we're talking about chronic pain or TMS, demedicalizing the patient, getting them, as you said, to go for a run or swimming pool or go for a walk is extremely effective. It burns off stress. It gives you the feeling that you're healthy rather than sick, which is a key transformation that has to occur. When you have pain for a long time, you believe that you're ill.
Yeah.
You believe there's something terribly wrong with you. If that's not the case, we have to turn that around.
Yeah. And what I might just add to that, if you have back pain, if you're in the mixed group where you have physiologic back pain and a hurt disc, and you've got some of the tension syndrome, if you got a bit of both, well, then it's a balance. You want to do some back exercise, get your core strong, do exercise that doesn't provoke your pain, but at the same time, don't get locked into this victim type of medical stuck situation where you're still being proactive.
Right. Exercise is good. Yoga is fantastic for flexibility and stretching. Any type of movement is better than no type of movement. And, just to believe, and then getting back into activities. Sometimes I have to talk to people like, what do you really want to do? Well, I want to play tennis. But you haven't played in 3 years because you've been in chronic pain. Let's just try to hit a few balls against the wall.
Yeah.
Just start out slow.
Right.
Don't start out by playing against a former tennis champ from college.
And that's the insanity I see with so many people is like, they're sitting around, they're not doing anything. Well, I got to train for a marathon. It's like, no, why don't you just get up and walk? Yeah. Let's start with just do a little bit, get out and move, and then work your way up.
That's an all or nothing mentality that can hold people back from progressing. For sure.
You also, you gave a great lecture to our physical therapy conference, and you also had some breathing techniques, didn't you, too? Isn't breathing a big part of another technique?
Yeah, I think that breathing is very important for stress and tension and anxiety, and I do talk to the people who are dealing with that end of it.
Yeah.
Work on some we call square breathing, where you're breathing in for a couple of seconds, or maybe 3 or 4, holding for 2 or 3 or 4 seconds, breathing out slowly for 3 or 4 or 5 seconds, and then waiting for a couple of seconds. So just kind of slowing your breathing has a tremendous effect. It increases the parasympathetic tone of the body. The sympathetic nervous system is the fight or flight system. That's when adrenaline gets running. And parasympathetic has that calming, anti-pain, anti-other conditions of anxiety and stress. So slower breathing can be very beneficial for that.
Yeah. What about sleep?
Sleep is very important.
Yeah.
Sleep is very important and challenging because how do people get better sleep? You try to stay away from the medication approaches because they tend to be very habit forming, but sometimes we can find certain medications that can be beneficial. And there's no doubt there's a tremendous amount of research on the benefits of sleep in chronic and acute pain and in health in general, that we're just not sleeping enough. NBA athletes now are really focusing on trying to get 7 to 9 or 8 to 10 hours of sleep a night.
Yeah.
And with their crazy travel schedules, et cetera, it's really proving to be difficult. But they've done tests on their agility and their ability to respond to different stimuli in sports, and they do much better when they're getting the right amount of sleep. So from elite athletes to chronic pain patients, sleep is very important.
How do you deal with athletes? Athletes tend to be such type A personalities and think it's so physical and just want the fix and move on. How do you convince them that this is psychosocial, mental, keep a journal without offending them and without them just walking out and going to somebody else who's going to give them a physical answer?
All right, so that's a good question. Many of the people that I see, and I've seen quite a few athletes, intercollegiate athletes, et cetera, they typically have to have failed a number of other approaches. So there's a saying in medicine that a lot of changes can occur when you're desperate. The person who's had a heart attack and you walk up to them in the hospital in the ICU and you say, you know what, you've got to really change your diet and start exercising every day. That's when they're going to make change because they bottomed out.
Yeah.
The person who drinks too much alcohol and then finally finds themselves knocked out, unconscious on the street is more likely to really realize they have an alcohol problem and address it. And similarly, the athlete or any pain-suffering patient who's tried a bunch of different approaches, nothing has worked. And people are starting to look at them like, I don't know what we can do to help you. We've tried everything. We've strengthened your core. We've worked on your flexibility. We've worked on medications. We've given you injections. Nothing seems to be, and I don't see anything on an MRI here that's going to help you surgically, so I don't know what to do at this point. Those people are more open to a different approach.
Yeah, it's an interesting how the full spectrum of everybody I know has some neck tension. And so getting some mindfulness and getting some breathing techniques and cardiovascular exercise and keeping a journal and processing this stuff, I think would benefit anybody to release some of that tension. And that's one end of the spectrum. Middle ground is people with mixed disorders, bit physical, bit of the mental component. But then the other end is just what you said. There's also the people who have been struggling for 2 to 3 years, seen a million doctors. the doctors tell them your MRI looks normal, and they're the ones who are really desperate. So you really do see the full spectrum.
I do see the spectrum. You know, an interesting post-operative situation that I've seen a couple of times in the last year, not from your patients.
Right.
It's a person has a disc, typical symptoms, they get operated on, pain goes away completely. A month later, the same exact pain returns. This happened on 2 different cases.
Yeah.
You've probably seen it.
Sure.
You've had a long career.
Yeah, you bet.
They go back to the surgeon.
Yeah.
He says, examines them, does an MRI.
Yeah.
He says, everything's fine.
Yeah.
The surgery was
Right.
successful. We
Right.
cleaned you out. I have no idea why you have pain.
Yeah.
These particular surgeons were not that attuned to the idea that, you know, maybe other things are going on. So this really demonstrates the concept of neural pathway pain, which is another way of describing this TMS condition that is a more modern, let's say, up-to-date approach as we understand more about the central nervous system in the brain. So the physical damage that occurred was fixed.
Yeah.
The pain went away.
Yeah.
But there were pathways in the brain that go down to the spinal cord and activate muscle tension and other things that are still present, and they get reactivated. Maybe a month later, a person had some anxiety, or their job wasn't going well, or they're worried about getting back to their job, issues at home,
Yeah.
and for whatever reason, it just triggers that pathway up again. And so the surgeon saying to them, there's nothing wrong, at this point makes them feel like, I don't know what to do. The guy says, I'm fine, and I have this pain.
Right.
I've been able to help those people because I explained to them, it's not that nothing is wrong, it's just that people are not looking in the right spot. We don't currently have technologies yet to see all of these pathways in the brain.
Yeah.
Maybe we will in 20 years or in 50 years. I don't know.
Do you think we'll ever be able to measure pain?
Boy, that's a tough one. That's a tough one. I mean, functional MRI imaging has taken us a long way toward understanding certain things in pain, but clearly it's still in its infancy.
Yeah. Let me ask you one other question, too, about these established pain pathways and the role of medications, and specifically narcotics and opioids, where, and my layman's term understanding is, if you take narcotics over a long period of time, your nerve endings get frayed. They undergo a chemical change where they need the narcotic. So you can get rid of the organic anatomic source of the pain, but the nerve endings are still frayed. They still need the narcotic. Is that, do you subscribe to that, and how does that play a role in what you deal with?
I may describe it slightly differently, but I do subscribe to it because people will be on pain medication long beyond it seems that they have anything that they need to be taking it for.
Yeah.
And you start to say to them, okay, we've got to taper you. You've got to go down from 4 a day, let's say, to 3 a day. They say, oh, my pain is massively more when I do that. But I try to explain to them in advance, the first few days it's going to be increased. But that's not because the disease is worse. It's because your body has gotten used to that degree of tamping down all your nervous system, your whole nervous system. And so your nerve endings are going to be hypersensitized for a little while as they sort of go back on board.
Yeah.
But if you can get through that first 4 or 5 days, research and clinical experience has shown that the pain will be as well managed on the 3 a day as it was on 4.
Right.
You do that for a month, and then we'll go down to 2.5 a day.
Yeah.
And so you have to do it gradually. Obviously, the education is important. Your explanation is good, that there's a sensitization or a sensitizing of the nervous system that has to be addressed.
Yeah.
Even with all that, it can be a challenge. You know,
Yeah.
sometimes we have to bring other medications into play, like the gabapentins and these sorts of things, the Cymbalta, different medications that can help with the central nervous system and just kind of calm it down a little bit.
Yeah.
The journaling, the breathing, all these things that have a parasympathetic effect can be of benefit, and it's still a challenge getting people off opiates.
It is. And what do you think? I mean, my general sense now is that people need to not look outside of themselves for the solution. They've got to realize that everything they need is inside themselves. Do you subscribe to that, or do you find that some of your techniques help refocus that, where they're not just chasing the next treatment and the next drug and the next whatever?
I love it. I love the fact that you're a philosopher surgeon. You know, they used to talk about philosopher king, but you're a philosopher surgeon.
Right.
But yes, absolutely, because people have been conditioned, if you will, or trained to believe that they need to find that next practitioner. They need to find that next body worker, or hands-on practitioner, or guru, or something. And really, the approach that I take is very much empowering the patient to get well. I'm not looking to see them 20 times. Many of the patients I see 1, 2, or 3 times, and the problem has been addressed at that point. I'm not against seeing them 4 or 5 times if I have to. My point is, though, that it's really more, as you say, about it's inside of them. It's about the choices they make. It's about the decisions they make. It's about getting more physically active. It's about dealing with some degree of pain, which you could call, as they do in Alcoholics Anonymous, the aches and pains of being sober.
Yeah.
When you're off of medication and you're dealing with life, you're going to have some aches and pains. And as we get older, into our 40s or 50s, whatever, you begin to notice some more discomforts. But that doesn't stop us from being active if we are determined to be so. And again, there are exceptions. I'm not trying to minimize the suffering of people who have terrible conditions. But I'm just saying that for the vast majority of the patients with chronic pain, just as you say, empowering them, explaining to them that you've got the resources with the help of the guidance from a practitioner, a physician like myself, a psychotherapist, that you can get better.
Yeah. What about research in this field? Has there been any real findings that have been proven? It's such a hard thing to prove, but is there anything like actually a head-to-head study or proven benefits in that way?
We're getting more in that direction. There's one of my colleagues who does this work in Michigan has been involved with some really interesting grants and studies that have been, a few of which have been published, smaller controlled studies, randomized control studies.
Yeah.
The functional imaging stuff is very interesting. You know, for example, acute pain, which is less than a few months, depending on who you ask, less than 3 months, or some people say less than 6 months, acute pain, is experienced in a part of the brain called the somatosensory cortex, right? It's where sensations are experienced. You sprain your ankle, you twist your knee, you experience pain, and if you image the brain, research shows you experience it in that area. What happens to that same person, either the knee or a back, but it's been 6 months or 8 months, and you put them in a functional MRI imaging scanner? Now, this is different than the MRI structural machines that we're usually talking about.
Yeah.
But these functional MRI brain scanners, a chronic pain patient, 6 to 8 months or more of pain, the pain is now shifted to the prefrontal cortex and the amygdala, a different part of the brain that is far more associated with the emotional centers of the brain. So I think, and this has been done by studies in Northwestern, at Carrion, and others, that is not specifically done on TMS patients, although we're, again, doing studies in that regard. We have a colleague in Colorado doing some imaging studies on patients with this condition treated in this method that we've discussed today. But what's so interesting is how chronic pain is a different animal than acute pain.
Yeah.
Yet many practitioners treat it exactly the same way.
Right.
It's not the same animal. You shouldn't treat it the same way.
Right. And that makes sense. A lot of times acute pain, doing prednisone, getting an epidural, knocking out the pain quickly is totally appropriate. Chronic pain is a whole different ballgame. That is more, okay, we got to shift your lifestyle and your expectations and everything else to treat it.
It's a different animal, requires a little more of a multifaceted, multidisciplinary, or holistic approach, if you will, to dealing with it. More research hopefully will follow, and we have a nonprofit organization now that is creating some funding for that.
Cool.
Yeah.
What do you see in the future? Where are we headed? What do we need, and what's on the horizon?
Well, there's a couple things I'm working on that I think are hopefully futuristic but beneficial. One is, how do you stop this epidemic of people having stress-related disorders? You know, we live in a stressful world. There's a lot of tension. There's a lot of pressure. One thing I'd like to do is to get this into the educational system at the middle school, high school level, young enough where people can be exposed to the idea that their emotional state, their emotional feelings affect their psychological health and their physical health, both, and show them and expose them to journaling and other techniques that we use. So I've developed a little bit of a curriculum, and I've got a couple of high schools that are going to be using this in a pilot program.
Cool.
And I'd love to get this out to a broader educational audience. Some of you listening today may have connections or be principals or other people interested in this approach. Yep. And this is all being done on sort of a nonprofit basis. We're really just looking to get the word out to people. The other thing we would ideally like to do is to train more physicians and psychotherapists and really expose more physicians to these concepts. I love the fact that you're explaining it in ways that the general public can understand, that your patients can understand, but also you have a credibility with the surgical community so that you can find ways to hopefully explain some of this to the surgical community as well so that they become more open to it. But physicians of all types need to be thinking, as they do now, about laboratory tests, about the physical exam, but also about what is the psychosocial state of the patient, what's been going on in their life. Ask them these kind of questions. It really doesn't take that much longer to do so.
Yeah.
It gets to the answer, so in that sense it could take less time rather than bringing them back over and over again and not getting anywhere. So research, more research, getting it to a younger population, and hopefully increasing the training of physicians. The nonprofit is also working on some training videos that people can access who want to learn more about this from a professional standpoint.
Yeah, it's awesome. There's no question, for all the hours we spend in the classroom from K to 12, how much do we actually learn about ourselves
Right.
and how to process things and deal with stress and figure out who we are and what's important to us. And you know, it's hard because obviously in a schooling system, you know, the parents are like, what, you're wasted 45 minutes doing nothing? So it's a real balance, but it's essential. I mean, it's the biggest thing you could get out of it.
We learn a lot of seemingly not practical things in school, and there's a big push now toward what's called social emotional learning.
Yeah.
And so this fits into that. It also fits into the fact that there's this vaping epidemic that we want to address. I mean, that's kind of has a psychological, emotional component. There's unfortunately a bit of a suicide epidemic at the college level and beyond that needs to be addressed. There's the opioid crisis that we're hopefully beginning to start to get a handle on. But all these things relate to people dealing with problems in non-constructive ways,
Right.
and not really looking at who they are as a human being and how to manage your life, how to manage your feelings, how to work with your feelings, and where necessary, seek help for your feelings. So I'm optimistic guardedly that these things can be brought into the system. There's so many things being taught in school. I understand there's a lot of competition for the hour or the session, but I'm looking to bring this in as perhaps 1 week in the middle school and 1 week in the high school level health education, and I've got some teacher training materials and PowerPoints and things for teachers, as well as a mind-body workbook for teenagers to use in this setting.
Cool. That's awesome.
Yeah.
And it kind of, you know, the world seems like it's getting crazier and more disasters and just getting worse in some ways. But in other ways, we're getting smarter at least. I mean, and I tell patients all the time, at least you live in Los Angeles where there are practitioners of yoga and Reiki and mindfulness and a guy like you and who do all these things that can fit with what you need. Whereas if you lived in the Midwest, people would say, you got back pain, suck it up and live with it. You're just like everybody else. Get back on the farm and keep working. And so in some ways, living in LA in this high-pressure society is crazy and a bit neurotic and develops its own problems. But to another degree, the good part is we're also getting smarter. And we know a lot of techniques and technologies to help even start at an earlier age. And also the technology. I mean, that's the thing I love about our app and your book and podcasts and stuff like that. Well, at least now we can just click a button and share some information and maybe help people all over the world, which is really cool.
I'm going to give a shout out to the Midwest and the flyover states since you were a little bit rough on them there. I've traveled a fair amount the last few years. You know, I was in Halifax, Nova Scotia this summer, and you know there was Pilates there. There was yoga places. I mean, I'm seeing in these smaller towns that I'll occasionally visit that there's a lot more practitioners that have some awareness of mind-body connections.
Yep.
We do need more physicians. We do need more psychotherapists. You know, my website and the nonprofit website list other physicians in other states and cities that do this work, as well as many psychotherapists and others. But clearly we need more of it.
Right.
But although LA may be ahead in some ways, you know, we're behind in other ways.
Well, it's also got the psychosis that generates the care. You know, so yeah, that's a win-win. You could live in the Midwest, have a more relaxed environment, and get all the information from what we learn in LA. That's the best of both worlds. So I'm going to put your link to your book and your webpage on the bottom because I really think ultimately if somebody's suffering from these type of issues, the next step is really to get your book, do the workbook, and process things and go through it. I'll put a link onto a podcast I made where I kind of summarize my John Sarno take, you know, and what the mind-body connection, what it meant, and you know, hopefully it helps people ways to process things. If anybody has any comments or questions, please put them at the bottom, and we'll respond to that.
I mean, an interesting phenomenon, is when people do read these materials, if they apply to them, they're often able to see it.
Yeah.
Now, sometimes patients of mine have been given one of these books, either mine or Sarno's or whatever, perhaps a year before. They just weren't ready for it. They looked at the book, a friend gave it to them, said, hey, this could make a difference in your life. They weren't ready. They looked at the book, put it on the shelf, kind of forgot about it, and then picked it up a week or two before they saw me, looked at it and go, oh my gosh, this is me, and they read through the whole book over the weekend and then call my office Monday morning desperate for an appointment.
Yeah.
Takes a while to get them in sometimes. But
yeah.
the thing is that expose yourself to these ideas. If you think it might at all apply to you or a relative or a friend, don't be surprised if there's some resistance on the part of some of the people you might mention it to. But I look at it as planting a seed. You know, sometimes you plant a seed in your garden and it grows. Sometimes it grows quickly, sometimes it takes longer. You just have to kind of plant the seed and hope for the best.
Yeah.
And then people who are open to this is one of the key stages. I have stages of healing in my book. A key stage is being open to looking at this problem with a new paradigm, with a new approach.
Yeah.
And I appreciate your contribution to that, making people more aware and making them more open to it.
Yeah,
well.
you bet. And that's exactly right. Read it with an open mind, see what a part applies to you, and take that part. And just what you mentioned, the fact that we're always changing and we're going to be a different person in a year from now and have different issues makes it a constant challenge, but also, constantly fun. Right?
Keeps life interesting. Right. Hopefully we're all growing and changing.
Right. Cool. Well, I hope that's been helpful for you guys. Like I said, chip in if you have any comments or if we can help in any way, and I'll put all of David's information on there. He's right in Culver City, so he's accessible, he's close, and for everybody who has any issues. Thank you so much for being here.
I really enjoyed it.
Everybody, cool. Bye.